Hello, my name is Christina Johnson, and I will be presenting on hyperlipidemia. So first off, I'd like to show my certificate of original authorship here. So what is hyperlipidemia? It is also known as high cholesterol due to high levels of fat proteins in your blood. Most people with hyperlipidemia are actually asymptomatic, but it does put you at a higher risk of developing heart disease. In this country, it affects 1 in 3 Americans. Some risk factors to keep in mind of our genetic predisposition, cigarette smoking, obesity, poor diet, and a sedentary lifestyle. There are actually 2 types of cholesterol. One is known as LDL, low density lipoproteins, and this is considered the unhealthy cholesterol. This actually enables the excess cholesterol to build up in a person's blood. The other type is HDL, also known as high-density lipoproteins, and this is your good cholesterol, which carries the extra cholesterol back to the liver where it will be eliminated. Davis states that hyperlipidemia is usually detected during a routine blood test or following a cardiovascular event such as a heart attack or a stroke. So there are 4 types of hyperlipidemia. One occurs in childhood, and it is the severe one. It's known as type 1. It can cause abdominal pain, repeated infections of the pancreas, and enlargement of the liver and spleen. It is known as a familial LPL deficiency, and it is inherited. Type 2 has 2 forms, A and B. Type 2A is also known as familial hypercholesterolemia, and type 2B is known as the familial combined hyperlipidemia. So both of these forms of hyperlipidemia lead to deposits of fat in the skin, around the eyes, and it does increase risk of heart problems later on in life. Type 3 is known as familial dysbeta lipoproteinemia. This causes levels of your LDL in the blood are too low, where your HDL levels are normal. It can cause xanthomas, which is flat yellow to gray plaques on the eyelids and around your eyes. And it does increase the risk of early onset cardiovascular and peripheral artery disease. And then finally, type 4, it does increase the levels of your triglycerides in the blood. It can lead to obesity, high blood glucose, and high insulin levels. This type of hyperlipidemia actually is noticed for more in early adulthood. So the pathophysiology of this illness is that excessive fat in the blood does accumulate over time, forming plaques on the walls of the arteries and blood vessels. So what happens is that too much fat in the blood narrows the openings of these vessels. It then produces an unstable blood flow through the blood vessels, causing the heart to work much harder as a result in order to pump that necessary blood. So other causes for hyperlipidemia are excessive alcohol consumption, obesity, use of medications such as the hormones and steroids, diabetes, kidney disease, hypothyroidism, and pregnancy. So cholesterol is actually naturally circulating in our bloodstream, and it's involved in the structure and function of our cells in the body. But when the lipid level is higher than normal, plaques begin to form on the inside wall of our arteries. These plaques, again, they will lead to reduced blood flow through our blood vessels, which does cause that narrowing and stiffening of the arteries. And ultimately, it leads to what we know as atherosclerosis. So pharmacological treatment for hyperlipidemia. Henry Chang and Hollander do state that therapy is based on the individual patient's risk category and LDL levels. So a normal lipid panel will be seen as following: total cholesterol less than 200, LDL less than 100, HDL should be greater than 40 for men and greater than 50 for women, triglycerides less than 140. Medications that are commonly used for hyperlipidemia are statins, and these are prescribed mainly to manage the symptoms of hyperlipidemia. So common ones are simvastatin, lovastatin, atorvastatin, and rosuvastatin. There are new medications out They are called PCSK9 inhibitors. These are actually being studied for people that have cardiovascular disease and need that additional push to lower their LDL. We also have non-pharmacological treatment options. As Davis states, rather than following a low-fat diet, the individual should minimize their intake of saturated fats, trans fats, and cholesterol. So fast foods, high carbohydrate foods should be restricted, if not eliminated, for a patient diagnosed with hyperlipidemia. The diet should actually include whole fruits, vegetables, fiber, and whole grains. Regular servings of fish, nuts, and legumes are definitely recommended. There is a diet called the Mediterranean diet, which should be adopted by the patient to help them lower their cholesterol level. Again, reduce saturated and trans fat and increase your polyunsaturated monosaturated fats. Besides a diet, regular exercise consisting of 30 minutes of activity 5 times a week helps lower your LDL and raise your HDL. An example of this would be brisk walking. Holistic options for the management of hyperlipidemia. There are a few herbal and nutritional supplements that can help lower your cholesterol. One of them is garlic. So this actually can decrease blood levels of your total cholesterol by a few percentage points. It should be used short term because it can prolong the bleeding and blood clotting time. Fiber is a supplement that you can take as well. Actually, to meet your daily fiber intake, it is recommended to add another supplement. This can lower your overall cholesterol level and your LDL. It does need to be increased slowly in order to prevent any gas and cramping. And with the increase of fiber, remember that you do need to increase your intake of fluids as well. Gugulipid, this comes from a gum resin of the myrtle myrrh tree. So this was actually used traditionally in a Ayurvedic medicine, which originated in India. This reduces blood levels of your total cholesterol and your LDL cholesterol. But unfortunately, there is not enough data for scientific validity to be used in the US. Red yeast rice is another herbal option. This lowers your overall cholesterol level. This is found in the over-the-counter supplement called Colistin. Unfortunately, in 2001, FDA removed Colistin off the market because it contained lovastatin. Currently, FDA does not allow red yeast rice to be promoted as something to use to lower the cholesterol. And finally, polycosanol. This comes from sugarcane. This lowers your LDL, and again, more studies does need to be conducted, mainly for the safety. Some side effects and contraindications of statins are that most common adverse effects are related to the GI system, but it only occurs in approximately 3% of patients. The more serious adverse events that could occur are hepatitis and myopathy, mainly myalgia. If these do occur, medication therapy can be discontinued for 1 to 2 weeks. And then again, statins are contraindicated in patients with liver disease, and they are considered a pregnancy category X. So I went in and reviewed 5 peer-reviewed articles. The first one is a relationship between the LDL lipoprotein cholesterol and coronary heart disease risk reduction. So this article actually goes over the risk markers that clinicians should be aware of when treating patients in order to improve their health outcomes with hyperlipidemia. There are currently some risk markers that have already been founded, but again, these go over the emerging ones. So a list of them are as follows. There's high sensitivity C-reactive protein, coronary calcium score, small dense LDL, HDL subspecies, homocysteine fibrinogen, apolipoproteins, microalbuminuria, metabolic syndrome, lipoprotein-associated phospholipase A2, carotid intimal medial thickness, and a coronary CT angiogram. So this study included a combined treatment to be used on the participants with pravastatin and a placebo group. This was done in order to see the significance in the progression of their LDL lipoprotein cholesterol level. So there were new tests that were included in the studies. One is the vertical autoprofile test, and this actually directly measured the small dense LDL. Another test that has been started used for these emerging markers are nuclear MRI. The second article focused on studies which evaluated how frequent lipid testing should be done in adults who have not been diagnosed versus those adults that have previously been diagnosed with dyslipidemia and have already started treatment. So systematic review of the literature was done in order to identify randomized controlled trials, systematic reviews, health technology assessments, and observational studies. This was done within a 2-year span. Canadian and international guidelines recommend testing for dyslipidemia in individuals at an increased risk for cardiovascular disease. The frequency of the testing is recommended based on expert consensus. So again, this is something that needs to be individualized per patient. Based on all the types of the studies that were collected, observational studies did not help in the formation of a conclusion on how frequent the lipid testing should be done in adults. But current guidelines do recommend that lipid testing be done, especially in those with, again, the increased cardiovascular risk, with the frequency of testing based on an individual cardiovascular risk. The third article focused on the use of statins as a medication of choice for patients who need that lipid-lowering therapy. So first, we need to acknowledge that treatment using these medications should not be based on just one lipid measurement. There needs to be at least 2 within a 2-week span. Patients' baseline tests also need to be done to rule out any other secondary causes, and liver function tests should also be done prior. Diabetes, thiazides, and beta blockers are actually secondary causes that affect someone's lipid levels. And then hypothyroidism is another diagnosis that does affect the lipid levels. Patients that are currently diagnosed with hypothyroidism are being treated for the thyroid disease, and that can actually revert the lipid level back to a normal range. One of the biggest concerns, though, with statins is myositis and muscle inflammation, but it is not common. And then again, myalgia does occur in about 2 to 10% of patients. In this article, there were 2 main trials that were done. The first one is called IDEAL trial. This included 9,000 patients with a history of an MI randomized to the highest dose of atorvastatin versus those at a starting dose of simvastatin. So the difference in the combined inputs of cardiovascular disease was stated by Veris that non-fatal MIs or cardiac arrest had no difference in the mortality. Again, Veris did state that aggressively treated groups had almost twice the discontinuation rate of the less aggressively treated group. The other trial that was discussed in this article was the ASTEROID trial. This included 507 patients that were treated with the maximum dose of rosuvastatin, which is 40 milligrams a day. The study did find that atherosclerosis plaques were shrinking, and this was done by using an ultrasound. Unfortunately, there were some limitations to the study. The first one was that there was no actual comparison group. The study did not measure vessels with greater than 50% stenosis, and there was no correlation with the clinical outcomes. The fourth article focused on the use of medications, specifically statins, in the pediatric population with dyslipidemia. There's growing evidence that the development of atherosclerotic cardiovascular disease does begin early in life, and this does include childhood. The prevalence of fibrous plaques considerably increased from 8 to 69% from childhood to young adulthood. And because of the rise in obesity, type 2 diabetes, and hypertension in older children and adults, this is something that needs to be focused. Treatment of dyslipidemia in children is similar to the treatment in adults. It involves both lifestyle interventions as well as pharmacological therapy, such as statins. Weight management should be considered the primary treatment in children who are overweight and obese before starting any pharmacological therapy. If it does need to be started, treatment options would include bile acids, sequestrants, and statins. 13 trials were reviewed, 7 were randomized clinical trials, including more than 50 pediatric patients. The best designed trials currently available for the use of the statins in the pediatric population involved lovastatin. The most recent trial studied the efficacy and the safety of lovastatin in children, but did focus mainly on the female population. The primary objective was to compare the LDL cholesterol lowering efficacy of lovastatin versus a placebo group. The lovastatin group showed a reduction in LDL of 27% versus a 5% increase in the placebo group. There was another trial concerning lovastatin, which was done in pediatric patients, but this one focused on male population. It did also investigate the safety measures of growth and sexual development in male children. At 24 weeks, lovastatin produced significant reductions in the LDL at all dosages compared to the placebo group. The continued therapy with the lovastatin, which was 40 milligrams a day, the dosage from 24 to 48 weeks did reduce by 25% versus the placebo. There were additional trials that were done specifically using simvastatin. So one was a multi-center double-blind study evaluating the efficacy and safety of simvastatin in about 173 male and female children between the ages of 10 to 17 years. At the end of the 48 weeks, the simvastatin patients showed statistically significant reductions in their LDL, TC, ApoB, VLDL, and triglyceride levels. Another trial evaluated the use of atorvastatin in children. This was a multi-centered, double-blind, open-label extension study involving 187 male and female children, again ranging from the age of 10 to 17 years. Children here were randomly assigned in a 3-to-1 ratio to receive 26 weeks of atorvastatin at a 10 milligram a day dose. After the 26 weeks, the subjects who completed the double-blind phase were eligible to continue treatment with an open-label atorvastatin of 10 milligrams a day for another 26 weeks to meet their optimum level. And Aylin and Luttrell do state that after analysis, they found that statins are currently an appropriate choice for use in the pediatric population. The last article that I reviewed discussed randomized controlled trials that were done in 14 community pharmacies in Alberta, Canada. The trials did include adults with uncontrolled dyslipidemia, which would receive a pharmacist-directed care. Pharmacist-directed care included an assessment of their cardiovascular risk, review of their LDL-C, medications that would be needed, and follow-up visits that again would be needed. The usual care patients, they did receive their lipid results, education including paperwork on cardiovascular disease, and continued care from their physician and pharmacist. The study population included 99 patients with a mean age of 63 years. 49% of them were male, and their baseline LDL-Cs was 8.37. Patients achieving their LDL-C target was 43% in the intervention group versus the 18% in the control group. Participants were also given a laboratory requisition to have follow-up fasting lipid profiles, CK, and ALT measures performed prior to each visit. It was stated that pharmacist prescribing resulted in more than 3-fold more patients achieving their target LDL-C level. Finally, I have here some patient education needed for hyperlipidemia. Mainly, changes in lifestyle activities and diet management are key to improvements in your cholesterol. Using the Mediterranean diet plan, again including soy proteins, fish, nuts, fruits, vegetables, and olive oil when cooking, is beneficial to the health. Remember to limit consumption of red meat and dairy. Kelly does state that improvements in your HDL cholesterol levels seem to be related more to the amount of activity than to the intensity of the exercise, which is why it's recommended to do 30 minutes of regular exercise 5 days a week rather than a longer and more intense exercise 1 to 2 times a week. Any person who is diagnosed with diseases related to hyperlipidemia, such as hypothyroidism, diabetes, and/or renal insufficiency, should have a lipid evaluation as part of their regular diagnostic workup. If your cholesterol levels do normalize with just simple lifestyle changes, then the need for medications can be reassessed at the time of your follow-up with your provider. And then Keep in mind that patients who are on medications such as lovastatin or atorvastatin should avoid grapefruit or grapefruit juice because it can cause an increase in their bioavailability. And patients should seek medical attention immediately if they do notice any yellowing of the skin or eyes. These are my references. And thank you for listening in.